Hi, everybody. This is Andrea Davis with Expect More, and I'm excited to bring you Dr. Meghan Bishop, kick-ass female orthopedic surgeon, and we're going to talk all things sports medicine, ACL related, and get into some running discussions. So, Dr. Bishop, thanks so much for coming. I appreciate it so much.
Andrea, thanks for having me. Super excited to be on the show today.
Yeah, so let's tell everyone a little bit about your background, where you come from, and what makes you tick, because you are a beast in every sense of the word, in the best possible way. And I've been so grateful to be able to talk to you, see some of your patients, and just learn a little bit about you know your experience in life and what's driving you forward. It's been pretty cool.
Sure, yeah. I'm a sports medicine surgeon. I practice at Rothman Orthopedics in South Jersey. In my offices are in Marlton, Washington Township. I've been in practice about 7 years now. Um, I do everything sports medicine, but certainly have a focus on taking care of female athletes. I really enjoy that. I do a lot of sports coverage in my practice as well. I really enjoy taking care of uh, young and more elite athletes as well. So I take care of Drexel's University. So I'm their head team orthopedic surgeon at Drexel University, as well as take care of one of the assistant team physicians for the Philadelphia Phillies. So that's a big part of my practice as well.
Yeah, no big
And
deal.
still, I can. Yeah, well, I love doing that stuff. It's really what got me to go into sports medicine originally. So I'm so happy that I've been able to incorporate it still into my practice.
Yeah, I think it brings a wealth of knowledge into this area, especially our area is lacking in female surgeons. Not that you can't take care of everyone, but specific. I do believe there's some specifics when it comes to dealing with the female athlete, especially teenage and collegiate female athletes that are nuanced. And to be able to refer to someone like yourself that gets that and they relate to the kids and the athletes in that way has been invaluable, really. And to have that kind of quality work and quality surgeon that that you refer to, and they resonate, and oh my god, they're like, she's the surgeon. I'm like, uh-huh, she is.
Yeah, I mean, I love taking care of young female athletes, and there's definitely, like you said, there's a lot of nuances to it, and every athlete you get approached differently, especially female athletes. So one of the things I found that there was really kind of a void in orthopedic sports medicine research when I entered was on female athletes specifically. So that's one of the things I've focused on, and it's been brought me a lot of joy in my practice, being able to kind of look at things from a different lens, as we haven't had a lot of female sports medicine surgeons in the past, and it allows me to kind of look at things differently and approach things in a different way. And we've done a lot of research in this, and most sports research on athletes is in males thus far. So we did a big review of the literature, and I think only 8% of studies were in the major four sports medicine journals were actually specifically on female athletes alone.
I
So
believe it.
70% were on like both, or excuse me,
Okay.
70% were on males, and then 8% only on females. And then the others were kind of combined. So like there's a huge void in looking at female athletes specifically. So that's really one thing that I've kind of made a passion project for me in my practice, to try to explore some of those, voids that we have, to find more answers to help treat our patients better.
Physical therapy in my career, 26 years in physical therapy, um, the incidence of ACLs is all over the place in research, as far as being younger, female, more viable, I guess, to that injury as opposed to the males. Can you talk a little bit about that? If that statistic that's out there publicly is actually true, and then I want to talk about the big thing that came out, I guess, with FIFA and soccer a little bit. Just curious on your comments on that, because that's not new information either.
Sure. Yeah. So when we look at research, we know that young women specifically, have a higher risk of ACL injuries. If you cite it, it's usually, like they say, between 2 and 8 times higher than males of the same age.
Right,
It's a very
right.
common injury both in males and females. That being said, but the highest risk age group is those young females that are ages 15 to 19 years old. And if you look at a graph of comparison between ACL tears in males versus females, you see a huge spike in ACL tears in young women in that age group, 15 to 19.
Okay.
Men, go higher, but they stay higher for longer. So I mean, like they don't peak as high, but their risk stays more into their, mid to early 20s. But you really have that high peak of those girls that are in that high school age. And, there's a lot of reasons that we've looked into that could be potential causes for that. And there's a number of different things. Some of it's just being, female hormones. We know hormones, estrogen, relaxin, things like that can actually predispose women to tear their ACL based on when they're in their menstrual cycle. Usually it's that ovulatory or follicular phase early on that they have that higher chance of tearing. Estrogen levels are higher, relaxin levels are higher. Those are things that can contribute to actual predisposition to ACL tears.
Hmm.
Testosterone's actually been shown to be somewhat protective against ACL tears too, as well as in kind of like
Okay.
lab studies as well. So that can be a protective factor. And then there's a number of different, neuromuscular biomechanical factors based on landing mechanics, based on kind of muscle imbalances, and kind of the way women's hips are shaped. So there's a number of different things that can put excess force on the way. Um, young girls are prone to land that can put extra stress on that ACL and make them more predisposed to tearing it. So that's actually the really interesting part is studying how we can kind of prevent those things and correct those. And that's where, you guys come in, Andrea, like with a lot of the ACL prevention type stuff and trying to correct those poor landing mechanics to be able to help, make sure ACL injuries don't even happen in the first place.
Well, it's the awkward, like we call it in house, we call it like the baby deer leg stages when they're in that, right? Because they hit their growth spurts at different points. So, 11, 12, 13, 14, and then they shoot up and they don't really know how to use their muscles in those planes. So they shoot up, and then in the ladies, the hips get a little bit wider, which changes then all the angles and what you're talking about with the chemical compounding with joint laxity, that like more looseness. So they don't have great neuromuscular control. They're predisposed to this looseness that is new to them, and they're awkward in these growth spurts. So it's almost, on a medical level, I don't want to say entertaining by any means, but you ask them to jump and land, and you're like, oh my good lord, what is happening? Right?
Right.
They're all over
Right.
the place. So I agree that neuromuscular reeducation at earlier ages is definitely seems to be speaking to that
Yeah, we actually
statistic.
did a really interesting study recently that looked at our regional schools around South Jersey, schools that Rothman takes care of, and we included, I think it was 22 different high schools. We had over 500 teams that were surveyed, and it was
Awesome.
like coaches or athletic directors that answered this, and we were just asking, like, are you guys using ACL prevention programs? Because there are a number of different well-established ACL prevention programs that are out there that can be administered amongst these teams to be able to help prevent ACL injuries in the first place. And we know that they work, especially when we know they work, especially with young women who have these poor landing mechanics. And only 3.5% of teams that responded are actually using these ACL prevention programs.
I
They're there and nobody's doing it. So, it's almost like
preaching to
a
the choir.
right. It's like a public health problem. But the reasons they said why they weren't doing it was just time,
Yep.
resources, the people to
Yep.
actually administer them, and just people not wanting to devote time away from practice and things like that. So
So
there's a lot of education that needs to be done, to our young athletes as well as coaches in the schools.
yeah, no, 100%. And we have been in one high school in this area for the last 5 years, implementing a injury, ACL reduction, injury reduction programming. And all it takes literally is 7 minutes after practice. 7 minutes, a 7-minute program. And we saw over the course of the last 4 years, we've seen between a 25 and 30% reduction in non-contact injuries with this particular sports segment. It's female soccer and field hockey. So it's like so easy. And there's ways that we can mitigate, coaches' time, practice time, and whatnot to trim down and really try and get that out there and get that result out there. But it is so frustrating, the amount of red tape with each district. So that's what my personal plight is, very similar to your research is backing up why it's needed. So
Absolutely.
that's my professional journey right now, is to try and cut some of that red tape, because now not only all those roadblocks that are being laid out, it's like, nope, I have your answer. It's not too much time. It's 7 to 9 minutes after practice. How do we get the data? Oh, we can test all of your kids in under 30 minutes and get data that we can then speak to. So it's really trying to educate and bring up to the administrative level as well.
I
the
think we can
value.
partner together on some of this at some point because that was we were doing that was kind of the pilot to see if
Yeah.
the need's there, and clearly the need's there. So yeah, you've got the next steps already going, Andrea, which is amazing.
Yeah, no, and it's actually it's plug and play at this point, which is really really awesome. So yes, I will be excited to talk to you about that for sure some more. Um, so tell me, one of the things that I loved in this last year, and you're the chair, you're the co-chair of Inspire Women in Orthopedics, correct? Did I get the
Yes,
title correct?
yes, that's correct. Women Orthopedic Summit. Yes.
Yeah, can you tell me more about that, because that was amazing. Like just feedback as somebody that went there, and it was very inspiring and empowering in ways that in my 26-year career I have not been. So one, thank you for that, and two, please, if you don't mind talking a little bit about that and how you arrived there.
Yeah. Well, thank you for saying that. That's exactly what we were hoping for out of the
Yes.
conference. So this is going to be our third year doing this conference called the Inspire Women of Orthopedic Summit. It's held in October every year. We do it at the Four Seasons. It's kind of a 1 day event that is for essentially women that are interested in kind of orthopedic care for patients. It's, for students, it's for early attendings, it's for physical therapists, it's for industry that support us. Hospital administration comes. So it's really for not just necessarily, orthopedic surgery people like me, but
Mm-hmm.
really just everybody that's on our team
Mm-hmm.
together. And the idea was to, bring these women together in a room and essentially uh, be able to have a safe space for networking and also for kind of promoting leadership development skills and uh,
That was my
giving
favorite
people
part.
like a path forward to how to be
Yes.
successful. Like the idea is to like tell these girls that you can do this. There is a way to do it and be successful in your career, and you should be confident in yourself. And here's some tools that you can use to be able to do that. So that was kind of the idea behind the conference originally. We keep evolving each year, kind of adding some more things in it, but um, yeah, I mean that's what we wanted out of it, and I'm glad that seems like what you got out of it, Andrea.
No, absolutely. And the fact that it was very, very cool to see, because honestly, like most of my career, I've felt pretty alone in a lot of ways, as far as feeling this passionate about sports medicine, this passionate about trying to make a difference and a change. And say what you will, I love my guy friends and guy colleagues and male surgeons, but it is challenging to break into sports medicine and be dismissed at some level, especially on a PT level. I mean, you're a different level. You're in a commanding. You're at the top of the food chain. Really, like we're kind of like, it's challenging as PT to try to get in there. It's definitely better in the last 5 years, but to hear some of the stories of how women were supporting other women on the journey, and then to hear some of the really awful challenges over the last 30, 40 years that are still taking place even now, as the numbers of women in orthopedics and orthopedic surgery, from what I understand, is still not where we would like it to be. It was very empowering and inspiring, and I got a big charge out of that, which I need every once in a while to kind of keep going. So it's pretty cool.
Good. Yeah, that's it. And we've had some really great speakers, and even we've had people in business, like the president of Jefferson came and spoke, and some of their stories that they tell are so amazing, and their pathways to how they got where they are in these like crazy leadership positions. So that's what we want. We are increasing our numbers of women in orthopedics. I think we're up to like 16% of residents now are females, and maybe 8% of practicing females are surgeon or are females orthopedic surgeons. But we need that number to increase, but we don't only just need more women, we need more women in leadership positions. So like that's the
Yes.
idea. We don't want to just stop at getting, more numbers. We want women to be chairmen. We want women to, take on those leadership roles. And that's still where we have a large dichotomy.
Yeah, and to co-champion, right? Like I think it was sponsorship versus mentorship was a big part of what was talked about, and what that actually looks like and means. And people don't talk about that really. And I was excited to know that I was participating in that. I think I told you, shared with you at the conference, those were my natural instincts to be doing that, but now I'm consciously aware of it so that I can do more of it for some of the younger clinicians, because we have a fairly large staff. I think we have about 23 to 25 employees right now, and the majority are women. We're about 85% female, and wanting to see them evolve and push into leadership. So thank you for that, because it definitely helped my little corner.
Yeah, absolutely. You're welcome.
So you're a runner, right? Still
Yeah.
blessed to be able to
As much as
run.
I can be. I don't I still try to run every day, I will tell you, but I have not run a race in like a year.
Okay.
So I'm still a runner, but yeah, but I am a lifelong passionate runner.
So talk to me about that in your practice. Like, how is the approach? Like, there's a different approach, obviously, to most different injuries, but the running mindset is definitely a different version of an athlete mindset. Where tell a runner you can't run, forget it. You might as well take cover and like start like bobbing and weaving. So, what
I
is
usually
this?
yeah,
Yeah,
I usually try not to tell people they can't run unless they really can't run. And
right.
people really can't run if they have a stress fracture or something like that, or bone stress injury. You can't run on that. You got to take time off for that. But a lot of soft tissue injuries can be managed with load management, can be managed with like some partial cross training on top of running. So like you don't always if you're hurt, you don't automatically just have to say you just have to stop everything. So like, I think that a lot of treatments, physical therapy, strength training, things like that can be really important in injury prevention and getting people back. You can change things with shoes. You can try shoe inserts. There's a number of things you can do. Just change your stride slightly to be able to kind of continue to work through an injury. But I think that, the main thing is when I approach my running injuries, I don't tell people immediately can't run unless they really shouldn't be running. Like a lot of times we'll try to see if we can get them better by treating the injury while still, adjusting training in some way.
Mm,
Um, so that's kind of how I approach it. And even in like my older patients that like running, that have arthritis and things like that in their knee, they go to a lot of people that like a lot of people immediately will say, "Don't run. You can't run anymore." And I'll say, I'm never going to tell you not to run if that's really something you want to do. But I would say you probably shouldn't run every day. Maybe you run, 2 days a week, 3 days a week, and then you bike the other days. So like
is
those
that
are
what you
like
mean
you
when you say load management? Is that what you mean by load management?
exactly
Essentially, like
exactly.
spreading it out.
Yeah, exactly. So you're not going to be running, 40, 50 miles a week anymore. You could maybe get enough work in to be 40, 50 miles a week, but you're going to do that through some other means. If you have an injury or you have some kind of arthritic change or something like that in your knee. Some of the best runners in the country, like there's one girl that won a bunch of NCAA championships last year, like did half of her training on an arc trainer rather than running. So there's ways to do it. You can still be a good competitive runner and you can be smart about it. So yeah, like I said, my mentality is not always tell immediately people to stop. There's ways we can work through it.
Well, it's the psychology too, right? Of shutting it down. Like sometimes that's just the like we had a lady, I won't forget her. I still interact with her all the time, but she had to run 10 miles. Like that was her thing. She had to run 10 miles because 10 miles was the amount of time she needed, that she knew that it would reduce her stress levels with her children that were she was having stresses at home and work stresses and whatnot. So we really had to struggle and talk about 10 miles doesn't have to be 10 straight. It can be, 3 here and then 2 here and then, 7 over here or whatever. And she eventually embraced that, and she's still running, but she can't hit that 10-mile marker, unfortunately.
Yeah, I mean, I think that's a good way to break it up. Obviously, what you're talking about is a little bit of the mental side as well of dealing with some of these injuries and issues, which, yeah, but runners can be a little bit neurotic about things, obviously. But I think, like I said, I think approaching it in a more team effort, and we're not going to just tell you you can't do things, is usually not the best way to approach it.
Are there any like myths out there that you can debunk with in regards to running? Like if I do this, I'll be able to do this type thing. Like you have to have this particular type of sneaker. Like how important is that?
Yeah, I mean, I don't know if I have any like specific myths. I mean, the people always talk about the 10% rule. You should never increase, your mileage more than 10% per week when
Hmm.
you're ramping back up. I think that's a pretty good rule. I think like also the rules of never trying to increase mileage and too much intensity all too fast. All these are good things to abide by if you're going to come back from an injury or kind of get back into training, because I find like a lot of our young high school athletes, when they start and they kind of just do a little bit of running through the summer and then get back in their first 4 weeks of practice, people get a stress fracture because you start doing workouts, you start doing more mileage, you're doing 2 days, you're doing races, you get spikes on. There's all these things that kind of compound. So I think slowly, building a base and incorporating all of that over, a 6-week period is better than kind of just hitting everything at once. So we can educate our younger high school runners to kind of work on some of that stuff over the summer and prepare and get your base. I think that will really be helpful in injury prevention.
Do you blow up in the fall when cross country hits
I do.
with runners?
Funnily enough, I don't see that many runners anymore in my practice. I see when I was in New York City, when I practiced up
Yeah,
there, I saw
yeah,
all the club teams. Like I was runners
yeah. Okay.
all the time. It was like half of the people I saw. I
Oh
saw so
wow.
much, and then you don't want to only see runners because
Right.
runners don't need surgery, and it's a lot of like babying people, like you said. But
Yeah.
I do like feel like I have special love for taking care of runners just because of my history. But I don't see as many as I used to, and maybe that's a
Well,
good
because
thing.
it's
But
non-op, right,
yeah,
for the most part, and they don't
right.
typically require, God forbid, anyway, with shin splints and as long as there's no compartment syndrome
Exactly.
happening.
Yeah. And I'll take care of exertional compartment syndrome and stuff every once in a while. But
Yeah.
thankfully, most runners don't often have surgical needs.
So then, transitioning to like return to run in ACLs, what time frame do you typically see that happening at? Like from where you sit and where your practice sits. Like when do you like to see that start happening?
So I usually say 4 months is probably the earliest I usually allow return to running. And then they
Okay.
need to have about 80% quad strength from that side compared to the other side.
Yeah.
So that's usually how I counsel my patients. You can start running on a treadmill, short, no uneven surface around the 4-month mark, as long as your quad is strong enough to be able to support it.
Okay.
And I don't know. What do you usually do?
Yeah, no, it's like 16 to 20 weeks depending on. So like a couple of our markers or at least my markers have been if they're able to execute a solid single leg get up from a chair, like sit in a chair appropriately and only one leg stand up and sit down, if they're able to execute that with very minimal weeble wobble, like that varus valgus component in and out of the chair, then that's one marker. Solid execution of a straight leg raise with zero lag whatsoever, and then tying those two together. We're fortunate enough that we have an Alter G, so we start them at 50. Yeah, so we'll start them at 50% weight bearing, walking, and then we won't release them to a full run program until they are able to tolerate uh, no pain, proper mechanics at 80% of load, like full load, and then they can go to like a run program. So we usually start that kind of around like what you said, around 16 weeks, give or take. So
Yeah, no, that's great. I mean, yeah, I wish as many people were as detailed as you because I do
thank you.
struggle a little bit sometimes with getting kind of standardized things like that to be able to advance patients on with different physical therapy
The
groups and stuff like
Yeah,
that.
the struggle with the running for me anyway over the course of my career, because I've only just had the Ultra G since I invested in it in 2021, and I'd been exposed to it before but never had like the I guess the level of depth of looking into ACL specifically. But that transition from normal walking cadence to a jog, I hated going through gait mechanics to fix all the weirdness that would come out with that first return to run in full load bearing. So one of the things that we've been able to shed with the Alter G is exactly that. Like there's very few gait deviations that we see because they've been able to do it, progressively on there. So that's been kind of a cool byproduct. Um, because then we're talking like, oh, you need more heel strike. No, you're landing midfoot. No, you're on your toe too much. Like trying to talk somebody like a layperson through what terminal knee extension is mid stance and all those things where it was not my strong point. So this kind of vacated that a little bit. So
That's great. Yeah, I mean, I usually think of Alter G's mostly for like coming back from a stress fracture or something like that. So that's a really great use for it too.
yeah, the unloading component's huge, and it's operating all the time, which means I have the mechanic out here once a year, all the time. So when you're doing your ACL surgeries, Dr. Bishop, do you have a graft of choice at this stage?
So
That's
I
always a
am about,
question we get anyway.
yeah, no, so I do about half quad and half bone patellar bone. So I
Okay,
actually almost like 50-50. And frankly, I'm very much more individualized on the patient and how I've been choosing that
love it.
recently. I feel like, skeletally immature, I'll do quad. So like if
Okay,
you have open growth plates, that I will do a quad and I'll try to do physeal sparing, meaning avoiding the growth plate on at least on the femoral side.
okay,
So because I will treat some pediatric ACL injuries. For my Athletes, I do look at their patella. Patellar bone is probably my like go-to for my younger athletes. But if I look at their anatomy and they have a really long patellar tendon or something like that, or they have like a lot of recurvatum, there's a couple things I'll look into, and then I might favor using a quad in my younger athlete than the bone patellar bone, just based
Okay.
on that anatomy of that patellar tendon.
Sure.
And then really for like my weekend warriors and all my patients that are probably, like age in their 30s, I usually will use a quad on
Okay.
those, a little high, less chance of anterior knee pain than the bone patellar bone. And, I think they were really nice, tight graft. And then over the age of 40, a lot of times I'll consider allograft on those patients.
Okay.
And then
Yeah.
because there's a great study from the moon. It's a large multi-center study that really like has this great graph that shows based on how you age and the chance of re-tear between autograft versus allograft. And once you hit that age of 40, there's really minimal difference between using
Oh,
autograft versus
okay.
allograft with your chance of re-tear.
I did.
It's less, you know, recovery for the patient because you're not having to take their own, graft. And also it's a little bit faster surgery and things like that. So,
Yeah.
I go based on that based for age.
No, I love it. I mean, the individualized, like decision based, makes sense completely. And there's been this overhaul, again, 26 years treating ACLs. There's been this overhaul and transition into like quad tendon as opposed to the BTBs, which just changes a little bit, not a ton, but it does change a little bit on expectations on the rehab side, which we've
Yeah.
made
What have you guys
adjustments
seen
for.
with like early on with quads? Have you noticed like a little struggle with getting that quad going or?
Yeah, I do. We have, and we are also like a secondary go-to. Meaning, if people go to start PT somewhere else, and then they end up coming to us at some point, which I see a lot of second opinions on that for later stage. The quad ones are the ones that they have not been hammered enough with terminal knee extension and getting a
I totally
solid.
agree with you. Yeah.
Yeah, the VMO is just sluggish, lagging, and then they're doing all this upper level stuff, and I'm like, you can't even do a straight leg raise or maintain a good VMO while we're doing basic stage one function.
Yeah, I think, from what I found, a lot of that is if patients don't, and I have really emphasized this, if they don't get that full extension back, especially after a quad, if they don't get that full extension back early, it's impossible to contract your quad. So
Horrible.
if you're missing like 2 degrees of extension and you try to, like anybody can try it, try to like have your knee partially bent and try to fire a quad, you can't do it. So like it's just like you can't do it. So like if you don't get that terminal knee extension, you're not going to be able to get the quad back, and that can be with the BTB too. But I would agree. I maybe see that occasionally more so in the quad. But yeah. So like I think it's all that early first 6 to 8 weeks of getting that terminal knee extension back.
And do you know what the most heartbreaking thing, honestly, for me, especially at this stage, doing like second opinions, or I don't want to say cleaning up, but like trying to help somebody get to that end stage where they feel good. It kills me when they come in and they're 2 degrees shy or 3 degrees shy. And you can say whatever about goniometric measurements, give or take 5 degrees, between measure. You eyeball and they have a lag of 2 to 3 degrees, and you have to sit there and explain to them through this whole process that you never got your full extension, or you did and then you lost it at some point because you progressed it in ways and we weren't just coming back around to the basics. And you start having to heel prop them again and sit on them and go back to like firing them up with NMES and blood flow. It breaks my heart because it's so not difficult to
Yeah,
to nail it in the beginning, and then it just adds some time. So that is one of my most frustrating points. To your point, extension, 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 extension all damn day.
for sure. And like I'm aggressive about taking patients back early if they're lacking in either extension or flexion. Like if I see a patient that's a little stiff in the early phase, I'll like see them back in like 2 weeks. Like
Mm-hmm.
I'll monitor them every 2 weeks. A lot of times I'll give a steroid pack because I think that sometimes takes down inflammation and really helps patients push it. I'll tell them you got to be in PT 3 to 4 days a week. Really working on this now. I'll get them a CPM. I know you guys probably don't like CPM machines, but some
Don't bother me.
people, young women, I
Yeah.
think some really benefit from that CPM machine. So sometimes I'll throw a CPM machine on there, and I know that's more for flexion, but um, yeah. And then if they're really not looking where I want them to be by 8 weeks, I'll take them back to the OR and either put them to sleep, bend and straighten it, and if it seems like it's not moving, then I put the scope back in.
You and I tag teamed on, or I was fortunate enough to tag team on one of your cases that was one of the most challenging for me, and I know as well for you because it was a unexpected difficulty in extension early on. And girlfriend's crushing it now. She's at college. She's playing soccer. She's doing really well, but she had that very difficult. Couldn't get it into extension, and like we fought through it and fought through it and fought through it. And now she's doing really good. So
Oh yeah,
it's
yeah. I've seen some of her social media posts like about back to playing soccer in college, which is great to see. But yeah, rather than belaboring it and just like making patients suffer, it's
yeah,
sometimes easier to just take them back, bend their knee. And for that specific patient I remember you're talking about, like she actually had real dense scar tissue. Like when
yeah,
she needed the
quick,
like she
real
would have never
quick.
worked through that.
Nope. And
So
it came so quick. So and if we weren't communicating, quickly, it would have just like drug itself out and been ugly.
right,
But yeah,
right.
no, it's good stuff. So what are some non-negotiables for you in healthcare there? What do you think in your own practice? Like how do you hold like what do you hold yourself like as healthcare is evolving and it's I don't feel that your practice is devolving at all in personalized care or personalized attention, but that is some of the general feedback and that's out there right now. It's just medicine in general is getting a little bit less patient centered.
Yeah, I mean,
So
I'm specifically like it was important for me to I like the private practice model that I'm in. So like it's physician run practice. We have control over pretty much everything in our
everything,
practice. As much as we can, obviously, besides insurance companies and like things like that control a lot of stuff as well. But
sure.
I can control my own schedule. I can um, mostly control my OR schedule. I can work with residents if I want to. I can do
Hmm.
research if there's a lot of like I don't have someone over, like a hospital administration staff or something that kind of runs my practice. So that I really like being in private practice and having control over that. And I think it helps me be able to treat my patients better and like be a better clinician and academic physician and things like that in general. So to me, that was important to try to stay in private practice if I could. That being said, it's not an easy pathway in private practice. There's more risk in it. There we don't have like the safety backup of hospital administration, a big hospital system that's kind of like paying us and things like that. Like if we eat what we kill, like you have to
Yeah.
work hard to be able to make money because it's all on you. You have to pay your own overhead, things like that. So like, which means for all your staff, like if I wanted to have a physician assistant that worked for me, that comes directly out of my collections. So,
Hmm.
those are things that make things a little bit more challenging. You probably have to be a little busier and do a little more work to be able to get some of those perks. But um, I really like having control of my practice, and I hope that we're able to still continue, this way. And I think we will. We have really smart people working at Rothman, and great like business administration behind us. But things get harder every year with all the changes in
They do.
healthcare and the increasing reimbursements and increasing overhead costs. So it's not an easy venture.
they I I'm with you, 100%
Yeah,
with you.
because you're a soul. You got the same issues, I'm sure.
Oh
So
gosh, yeah.
yeah.
Yeah, the game is real. The game is real, and it's not just to small private practices. It's just private practice in general in healthcare. But I think you do a great job, and that comes through in your patients. And so grateful to have the opportunity to work with you. And I appreciate your time today, Dr. Bishop.
Yeah,
It's
thank you so
awesome.
much. Thank you for having me, Andrea. Hopefully we can get together soon, and I'll put a plug in
Yeah.
if anybody wants to come. Our Inspire Summit or Women Orthopedic Summit is going to be on October 10th this year at the Four Seasons again. So the day starts with some yoga, so you can come in yoga gear, and then great speakers and hopefully a cocktail hour at the end. We're still working on all the final details, but the agenda should probably be posted within the next few weeks to a month.
Yeah, no, that's amazing. And if anybody's interested in learning more about you and your practice, where shall they look?
So they can look just on the Rothman website.
Okay.
So we each have our own physician page, so you can take a look there.
All right. Sounds great.
All
All right, for
right,
everybody. Thanks, Dr. Bishop. Bye,
great. Thanks,
everybody.
Andrea.